there's a little bit of a difference in the title that you'll see here and probably what I'm going to talk about. So I don't have all the answers to the gaps between where we have been and where we need to be in terms of performance improvement. I plan to, these guys asked me if I would just talk to you guys about how I approach performance improvement in the world of emergency medicine where I work. And so I figured I'd share about 20 minutes of that with you all and just give you a chance to ask some questions. And I have a little bit of a different perspective on it coming from the United States, and I'll share that with you in a minute in terms of the model and the financial structure that I work under. So, we're going to talk about performance improvement, and I loved hearing James's talk this morning, and it's funny when you run in these circles, the same concepts come up. So you'll hear me kind of echo some of the sentiments that James presented earlier this morning. So this is my world. So I'm responsible for 416 emergency departments in the United States. So I'm the chief clinical officer for emergency medicine for Team Health, and it's an interesting arrangement because we provide doctor staffing but nothing else. So imagine that. I mean, you all work in your environment where you've got doctors, you got nurses, you got administrators, you've got all the challenges of improving in that environment. I have the additional challenge of being a complete outsider trying to influence those folks that I have no control over. So it's kind of an interesting twist there. So we see about, in aggregate, 13 million patients a year in all of these emergency departments, and also service other service lines within the hospital. So like I just mentioned, again, we're sometimes the doctors looking inside, trying to impact change that we know needs to happen in the ED. Some of it may be our fault, or some of it may be gaps in the doctor provision of care. Some of it may be gaps in the nursing staffing or provision of care. Some of it may be, just like I've heard all day today, the higher-ups not understanding what you're dealing with at the front lines, or budgetary constraints that are not allowing you guys to have the resources that you need. So we face all of those challenges.
Again, this is the USS Montana requesting that you immediately divert your course 15 degrees to the north to avoid a collision. Over.
Please divert your course 15 degrees to the south to avoid collision.
This is Captain Hancock. You will divert your course. Over.
Negative, Captain. I'm not moving anything. Change your course. Over.
So, this is the USS Montana, the second largest vessel in the North Atlantic Fleet. You will change course 15 degrees north, or I will be forced to take measures to ensure the safety of this ship. Over.
This is a lighthouse, mate. It's your call.
So sometimes I feel like I walk into that scenario every day, right? And lots of times it's just a lack of perception or a lack of understanding of where the other person is, either in their level of education, their level of understanding of the problems that you're dealing with, or other factors. So lots of times I just reach out and I try to listen and hear what people have to say. So, everybody, like James said, it doesn't really matter what improvement methodology you follow, just as long as you follow one. I happen to have a set that I feel really help guide me to the right answers, and I'll just kind of highlight these in the next few slides. But I follow lean healthcare principles, but only in that they are a quick, readily communicatable set of principles that allow me to, in a very short period of time, connect with folks so that I can set goals around the improvement efforts that I'd like to obtain. Queuing theory, theory of constraints, and I think James mentioned all of these earlier this morning. So what is lean? And I know, in some places, some countries, some towns, lean has a bad connotation because of maybe external variables or people that have tried to influence or develop lean. I like lean because it's straightforward, and you all do all this. Every presentation I saw today had a process map associated with it. The thing I like about lean is that you have two things. You have value and you have waste. So where are you creating value for the patient? Where are you wasting, where are you wasting the patient's time? And so as far as I'm concerned, if I eliminate waste from the patient's perspective, then I'm actually going to lighten the load for my providers as well, for my nurses, for my whole entire system. That's going to free up resources to commit to other things. The third principle is promoting flow and developing pull systems. And sometimes that's unfathomable in healthcare settings, right? Imagine, what is flow? What's flow? Keeping things moving. Sometimes I ask people that, and then I put up a video of Niagara Falls. You know, just continuously moving water. And I would argue that in healthcare, we rarely see that because we don't have the systems designed to properly to plan for flow. And so, and then continuous improvement is the other big element about lean healthcare. And for continuous improvement, I heard a lot of you all talk about this framework that you use, and a lot of people use a similar framework. Most of the elements in here, James talked about earlier today. But, you know, it's that guiding, it's first of all, what's your burning platform? What is it that says you can no longer continue doing what you're doing today? And then creating this guiding coalition. James put up a slide that showed the team that you put together. So who's your senior sponsor? Who are the people that you're going to have on the team that are promoters? Who are the people on your team that are going to help you achieve your goals? Patients are great team members. Also, I like to have resistors on my team. I don't want a resistor leading my team. That's a bad deal. And sometimes I walk into that. As a consultant, you walk into a person who is incentivized to have you fail because they set up the current system and they think it's going to work better than anything you could design. And boy, if somebody externally comes in and tries to fix things, what does that mean for that person? That they couldn't do it on their own, right? So there's a lot of factors at play here regarding this change management. And you can read the rest of the list, but I kind of follow this as closely as possible. Maybe not deliberately enough, but I try to build all of these elements into improvement projects that I work on. What are these dogs doing? They're queuing. So, you know, I ran into a queue this morning with Mark and James. James was carrying his two suitcases, and Mark was, and we were three guys lined up, and the tube pulled up the Piccadilly line, and it was jam-packed, right? You couldn't get on there. And Mark managed to squeeze in one door, and then poor James and I are walking down the next door. James squeezed in the next one, even with his two suitcases, and I get to the last one too late. So these guys left me. But so I just wanted to point that out. They did apologize. James just realized I was here, by the way, at lunch. So anyway, yeah, they're queuing. So queuing, if you don't invest a lot of time or effort in queuing, it would be a good thing for you to know very well because it impacts everything we do in healthcare. In the basic, it's a science queuing theory that was developed by a guy, a Danish guy who was trying to work on telephone responsiveness and call-in lines in 1917. And basically what he found out was, you know, there's these arrivals to these servers in any system you look at in the entire world. I don't care if it's Starbucks, I don't care if it's a lunch line, I don't care if it's toll booths that cars are driving through. Any system has arrivals and arrival rates and servers and service rates. So where there's a mismatch between those two things, you build up a queue. And these are examples of ED queues. So this is a queue for lab draws. This is a queue for what? Beds or patients going upstairs. This is a queue for what? The queue for the doctor waiting to be seen. So, and it turns out, if you just realize those things, which is every system has an arrival rate and a service rate and variation associated with both of those. So if you realize those four things about any system, you can calculate everything I have shown here. You can calculate the wait time. You can calculate how many people are in your system, how many people are in line. So you can do a lot of damage with this basic set of equations. So just Google queuing theory and read about it if you haven't heard about it before. So with that in mind, the way I approach emergency medicine is I just try to define the arrivals. So whether I'm talking about a 110,000 visit emergency department or a 20,000 visit emergency department, I try to define the arrivals. And like James said earlier, I try to make everything as simple as possible. I could break out every chief complaint that arrives at an emergency department and design a different pathway for each of those people, and pretty much I'm going to go nowhere. So what I do is I break them out into sick, easy, and complicated. So the sicks go to one place, the easies go to another place, and the complicateds go to another place. And it might be that you're such a small ED that you only have all of these people go to the same place. Might be that you're so big that the sicks go that way, the easies go that way, and I deal with all the complicateds up front because I have a bed problem in the back. And I have a doc see them when they walk through the door to help me get things rolling. So on the arrival side, this is how I look at arrivals. And then on the capacity side, same thing. We have tons of people running around the emergency department, but at the end of the day, we have nurses, doctors, and beds. It turns out every other thing working in the emergency department supports one of these three functions. So the key thing about these servers is they each have a capacity. And you guys that work in emergency departments, if you work anywhere, your servers have a capacity, and if the demand is greater than that capacity, you're going to what? You're going to have queuing. Turns out, even if the demand is less than the capacity, if there's lots of variation, you're going to have queuing too. So the key thing is to understand the demand for all of these servers and figure out what their capacity is and make sure that your system is designed to accommodate the demand coming through. And the last principle, which is kind of a build on queuing theory actually, is something called the theory of constraints. Who's heard of this? So the theory of constraints would say, if I've got these three servers in my emergency department, I don't have to fix doctors and nurses and beds all at the same time. I just have to figure out which one is the most constraining to flow. So the biggest constraint we call the bottleneck. So if I focus my efforts, those of you guys who have 20 or 30 performance improvement projects going on, all focused on flow, you've probably got 28 or 29 too many. A better plan is to focus on that bottleneck, wipe out the bottleneck, and then do what? Look for the next bottleneck. That's the highest leverage strategy you can take, is to wipe out the bottleneck, remeasure, wipe out the next bottleneck, remeasure, etc. So, and we follow the model for improvement. PDSA cycles are Deming or Shewart, whoever you want to attribute to creating these. It's part of Lean. It's a part of most successful improvement organizations. So this model for improvement. So on the plan part, I'm going to just show you a couple things. We don't have time to go into it in detail. But what I try to figure out is, how is my ED performing? So if I were a patient walking into that ED, what would I experience? So I measure things like volume, admission rate. I look at these key intervals, like how long is a patient going to be in the department? How long is it going to take them to get in front of a doctor? And then I measure what's my productivity of my doctors and my nurses. Okay, and if you notice, I have all these benchmarks against national averages. So I can tell whether that's good or bad relative to everywhere else. And what does that tell me? Sometimes I just say, well, benchmark against yourself. Well, that's great. So as long as you're improving, that's a good thing, right? But benchmarking kind of helps you know what's feasible or what's possible or what other people are doing. So I like to at least reference that to say, hey, we're either really good or maybe we're close to being average. But if I can kind of quantify that, I can engage people because it's an objective measure. So what I do with that information is we create these profiles, And these are arrivals literally by every hour of the week. And they're broken out by acuities. So green is low, yellow is medium, and red is high. And each one of these little bars here, which I think Tom told us earlier, don't ever use a bar chart. So just beware, I use this one a lot. So every hour of the week, this is Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, I have an understanding of how many patients are trying to get into my emergency department. So it turns out running an ED is simply queuing theory at every hour of the week for your key servers. And then I line up here, this is my demand for number of doctors, so I calculate how many doctors I need at each of those hours of the week. The red is how many I have, the blue is how many I should have. So this is, we load up the schedule and we go, hey, you know, you've probably got some excess resources on the weekdays here. And again, too much to really go into in great detail here, but the point is demand, capacity, alignment, and matching. And what you'll typically find in these, when you do them, is there is some free patient experience to be had. So what do I mean by free patient experience? Well, if I move a doc who's got a relatively low utilization from, say, the overnight to the day, or from the weekend to a busy Monday, well, the patient experience, it's going to make that doctor on Monday less utilized, and it's going to make the average patient experience better without compromising so much the patient experience on the Sunday because the utilization was low. So what we do is we bring all this stuff together, we model it, and then we work with our EDs to visualize this and see it objectively. And one of the things that we do is, let's say your door to doc is too high. Well, we have all these educational modules. So I talked earlier about, let's see.
Hi, this is Jody Crane, and I'm super excited to talk to you guys about ED best practices door to.
So in other words, if you're looking at this tool and you say, and it shows your door to doc is an hour, and it really should be under 30 minutes, well, this video is going to pop up and it's going to say, click here to learn about how to fix that. And so I think the key to the future is around analytics, but I would say around prescriptive analytics, right? So analyzing what's going on, but then giving some options about what you can do to fix it. Because we can look at dashboards all day, and they can tell us whether we suck or we're good, right? But at the end of the day, if you don't have the capacity to fix it, we need to change that capacity within you and your team. So we guide them on the analytics side. And I'm going to run you through just a real brief case study here. And the point is, up to this, you know, I've talked to you about the philosophical approach, the science, the technology, so to speak. But at the end of the day, where does all that get you? It gets you right up to kind of understanding what you have to do, right? What's the hardest part? Doing, right? Execution is the hardest part. And so I'm going to show you, so we do all this, and then we decide what is the intervention that we need to do in this particular site. And I put this list up here because, remember, I'm an outsider. Every ED I walk in, I'm some person from the outside. So I only get as much time as they give me. So they might say, hey, you can have 2 hours. Hey, you can have half a day with my team. And I try to get everybody who touches the patient who's going to transform that process. And if I only get a half a day or 1 or 2 hours, my focus is just on understanding what they understand and trying to engage them that there's a different way to do things. That's the only objective. If I get half a day, I spend the first part on that, and then the second part going, boy, there's a lot of cool things we could do, and trying to engage them that way. Some of them will go, yeah, I'll give you 3 days to fix our ED, and we'll give you all the resources and support, and you can do a lot with 3 days. Again, I heard a lot today, people struggling to gain the resources or the funding or the support to get people to work on projects, especially doctors. And I just try to appeal to their interest, their sincere interest to make their work environment better. It doesn't always work, but it sometimes does. So this Baptist Hospital, 100,000 visit emergency department in South Miami. And actually, I took this presentation, this is as is that they developed. So I didn't put this presentation together. This is a presentation that the team put together. This was their first really big improvement event. And so what were their aims? You can read their aims here. They wanted to drop their length of stay. They wanted to drop their door-to-doctor times. They wanted to maintain quality. And the thing that they were struggling with, so what was their burning platform? I'd wanted to work on this ED for 2 years, but they kept telling me no, 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 no. And all of a sudden, overnight, they had a huge boarding problem. So these patients piled up in the emergency department, consuming 40 of their 80 beds. All of a sudden, they had this left without being seen rate that went up into the 8% range. They had dissatisfied docs because our doctors in this particular hospital were paid based on how many patients they saw and the acuity of their patients. Imagine being a doctor who gets paid based on your productivity and not being able to get patients through the front door. That's a burning platform, right? Hey, Crane, please come help us because we're not getting paid, right? And I've been in that situation before. So, their metrics were not doing well. So we held a Kaizen event, and this was some specifically trained folks in Lean. We had several folks, Kaizen facilitators, myself, leadership. This is the whole team. And this was there's probably 30 people involved in this. And you could argue, wow, 30 is a lot of people to kind of wrangle in over a 3-day process. Well, what if I only had 15, but there was 15 people that touched the patient that weren't there? Are you really going to understand the way the process works, and are you really going to get the buy-in to fix the problem? So the way it worked is on day 1, we did some observations, we did some education. On day 2, we brainstormed and created the work groups to solve the problems. And literally on day 3, we were done, burned the bridges, changed forever. And I'll show you some of the cool things that we did here. So this is our mapping event. This is us doing the walkthrough. So typically you walk through, you map, you identify the areas that you're going to fix. This is our education. This is one of our teams that was doing a process mapping part of the engagement. Now this is the waiting room, and one of our big things was this registration area, which was in the main ED right next to triage. This registration area was taking up space. It was very uncomfortable for patients, and the team wanted to use this as a clinical area. And they had tried to move this area for 10 years, unsuccessfully. And one of the things about these Kaizen events that's real empowering is the group is literally empowered to act, and they're supported all the way up to the top because you arrange that stuff ahead of time. So we had a good idea we were going to do this. So we made sure that the IT folks were there, that the environmental services guys were there, that the engineers were there. And this is them literally on day 3 running electric and Cat5 cables from here, see that? From here all the way over to there. And I'll show you, and this is them moving the whole registration apparatus out front, freeing up that space. So this is before, this is what it looked like afterwards. So we created 12 treatment spaces with one kind of visitor space for each one of those. And we also totally re-engineered the place where the doctors work so that they could work right up in front of the ED. And the goal was to get these teams that could just act when the patient arrived instead of that classic triage back to the waiting room and, oh, when we get a bed, we'll get a bed. So our goal was to connect doctors and patients together the minute they walk through the door. So, this is kind of busy, but the team diagrammed up what they wanted to do, and it was basically, we call this an intake team where patients come in and There's this focused upfront effort to care for patients. And so we implemented this in June. And prior to June, their left without being seen was 5 to 6%. And the 1 month later, it was below 1%. And it's carried through permanently. And I know Tom's like rolling over in his little computer because this isn't a really great example of a control chart or anything like that. But sometimes I just use run charts. Just like James said earlier, like sometimes run charts are the fastest way to kind of get information out. But man, drop from 5% to 1%. So that's 4,000 extra ED visits. So that's about $1,000 for the hospital for each one of those in the fee-for-service American world. So that's $4 million for the hospital, about $1 million for the physician group in 3 days. And again, it's engaging all of these folks to act. This is door to doc. It was in the 100-minute range in January of this year. Now it's hovering right around 30 minutes, and that was their target. And again, not pretty, but this is the thing they put together. So after that, debriefing, optimizing the process, education, hardwiring. So after those 3 days, there's about a month or so where we're kind of hardwiring all of these things. And then act once it's kind of stabilized. So once we got it stabilized, we uncovered the next bottleneck, which was moving patients upstairs. So we started working on the back end in the rest of the emergency department. And we realized that there were a bunch of patients clogging up beds back there that were consuming beds and nursing resources, but not doctors. So we closed one whole part of the ED, 20 beds, and we made that an admitting unit, and we shifted all of the other resources to have lower doctor-to-patient ratios in the rest of the department, enabling us to stay on top of them. And the system that they designed was each one of these other teams, so this is where all the admits would go, all these other teams had their own little intake rooms. So they could pull them right out of the waiting room and pull them right onto their team when they were sick. And this is the entire team that did this project. And they were, as you can see, they were thrilled. This is the first performance improvement project this team ever did. And wildly successful. And now they're on a roll. And I always struggle with the sustainability part, but I firmly believe if you've got an engaged administrative support, you've got good to excellent leadership, both on the nurse and the doc side. It's a total team effort. But you see there's lots of nurses, charge nurses, frontline docs. None of these people were getting paid to do this. They were here because they had a burning platform to fix their emergency department because they did not like their work environment. So this team is going to sustain the effort even when some of the leadership is in doubt. I've been through these projects in my own shop, and there's been weeks when I'm like, oh my gosh, we can't do this. And what happens? My 3 other champions are going, come on, Crane, let's go. So everybody's going to fall down a little bit, but the whole team can pick everybody up. So anyway, I hope, so now repeat 415 more times. I hope you guys can see, and I wish I had a little bit more time, but 20 or 25 minutes on how I approach or how I see or view emergency department improvement.